Thank you very much, Professor Mahrous. Ladies and gentlemen, I want to start by thanking the organizers of the Egyptian Fertility and Sterility Society, and particularly Professor
Hassan. His talk is ovarian reserve as guide to ovarian stimulation.
Thank you very much, Professor Mahrous. Ladies and gentlemen, I want to start by thanking the organizers and congratulate the society for its continuous success, and thank Professor Gamal Abu Surur for extending this invitation to me. مش بتحرك ليه من هنا؟ بتحرك من هنا بس؟ مش بتحرك الشاشة بتتحرك. ما أنا بالأرز مش بتحرك الأرز ومش بتحرك من هنا. Okay, my contribution today is about ovarian reserve and whether we can use it as a guide to ovarian stimulation. I'm going to start by reiterating the fact that today we have more than 8 billion babies who were born to the technique of IVF and the related techniques. But of course, it does not always succeed. As we all know, it's about 1 in 3. These are the amount of statistics. And if we repeat IVF 3 times, it's about 2 in 3. So there are people who do not become pregnant after all this. And some of, for many reasons, of course. But one of the reasons is the poor ovarian reserve. But what is ovarian reserve? Ovarian reserve, literally, ovarian reserve is the number of oocytes which are remaining in the ovary at a certain given time. And it's thought to reflect the potential for becoming pregnant and producing offspring. But here we have to differentiate between two things: true ovarian reserve and functional ovarian reserve. Because true ovarian reserve, to obtain this, we have to do histology. We have to remove the ovary and cut the ovary and count the number of oocytes, which is not practical, of course. So what we do is the functional ovarian reserve, which is the ovarian response. So this ovarian response, of course, can be poor, can be adequate, or can be excessive. So ovarian response, ovarian response. What is ovarian response? What is poor ovarian response? We stimulate and we look for the response. We stimulate and look for the number of follicles which are growing by ultrasound. We stimulate and measure the amount of estradiol which is produced by the ovary. We stimulate and see the number of oocytes we are collecting at IVF. Of course, if we are going to look at follicles by ultrasound, I'm going to say there are 8 follicles. My colleague will say no, there are 9 follicles. If we are going to measure estradiol, and laboratory will come up with a number, another laboratory will come with another number. But if we stick to the number of oocytes collected, this is an integral number. It cannot be 7.5 oocytes. It's either 7 or 8. And this brings us to this very important paper, which was published 20 years ago, 21 years ago by Sari and Schoolcraft. What they were trying to do is to compare strategies for improving ovarian response in poor responders. And what they have found is that people are using different definitions for poor response, at least 28 definitions at that time. So what we thought at that time is maybe to come up with an objective definition. And the way we thought about it, we said the following. If I have 10 oocytes and my success rate is 35%, and if I have 5 oocytes only and my success rate is still 35%, why do I have to obtain 10 oocytes? 5. But if I come down to 4 oocytes and then my success rate drops to 20%, therefore at this stage, this must be the cutoff point at which a poor ovulation poor response should be defined. So poor response is and we did this and we published it many years ago. So at that time, this study is 754 patients, and what we found is the following. Are you talking about patients who are going to do ICSI, where you have a very clean pelvis, and you want a certain number of oocytes to achieve the pregnancy? Or are you talking about somebody who has an IVF and a very complicated pelvis with a lot of endometriosis and adhesions and infections and so on, in which case you may need an extra oocytes, for example, to achieve the same number? Or are you talking about the person who is doing testicular ICSI with testicular biopsy, non-obstructive testicular azoospermia, for example, and you're using very bad oocytes, in which case you may need a higher number of oocytes, in which this is exactly what we found. We found that in ICSI our cutoff point was 5, in IVF was 6, in TESA was 8, and then we came up with this definition. So our definition was 5, the cutoff point. 1 year later, Van der Gast published in 2006, he found the same thing, 4, his cutoff point was 4. Darkopoulos, 10 years after that, said 4, and then Porizos, a few years ago, said it was 7. The other side of the coin is the definition of hyper-response, which has been done by Magnusson in Scandinavia, and he came up with a figure of 18. However, most of the people will stick to 15, but statistically speaking, scientifically speaking, evidence-based debate is 18. So, enough for the definition. What is the prediction? How can we predict this response then? There are dynamic tests and dynamic static tests. As I said, dynamic test, you stimulate and you look for the response, which has been done by many people. For example, by Gauthier Dereur, he injects GnRH and looks for the response. Renato Francher from France injects FSH and looks for response. Tambo gives clomiphene and looks for the response. But of course, it's too cumbersome. So people stick at static markers like the age, like the basal FSH, inhibin, and so on. But to cut it short, we know that AFS, AFC, and AMH are the two important ones. But which one of them is more important than the other? The right way of doing this is to do receiver operating characteristic curves, ROC curves. This is the way to evaluate a predictor, to evaluate a prognostic test. So this has been done by Ali Azemi, and he found that AMH was better than FSH, they say FSH, better than inhibin B, and better than AH. He was trying to look at ovarian reserve, predicting ovarian reserve. A nice curve, because when he started to predict pregnancy, the curve was not good. It was a very flat curve. And why is this? Because pregnancy does not only depend on the number of oocytes you collect. You may have a good number of oocytes, but you may have a problem in embryo transfer. You may have a problem in endometrial receptivity, and so on. So it's always like this. If you want to predict pregnancy, you have to make sure that the other factors are not playing. It's more difficult. So this is, we also have AFC and follicle count, as we know. We have the average, and we have the poor, and we have the excessive. And the same thing has been done by Cui, and they did the receiver operating curve. And what they found is that the cutoff point for AFC for poor response was again between 5 and 6, and for hyper response it was 15 follicles that you count on AFC. So AMH is better or FC is better? Now this is Brouwer did this. The beauty of receiver operating characteristic curves is that you can compare the predicting power of any test you're doing. So he found that if you're looking at poor response, AMH is slightly better than FC. But if you're looking at hyper response, AFC is slightly better than AMH. Okay, so the question now is, can we use these predictors, AMH for example, to choose the ovarian stimulation protocol? We have two people here. We have Nelson and we have Yates. To summarize, Nelson said what? Said, if I have my AMH, mind you, AMH here is measured in picomole per liter. We measure it in nanomole, in nanogram per milliliter. So it's picomole per. He said, if I have it between 5 and 15, this is the normal response, the average. So in this case, I'm going to give the long agonist protocol, and I'm going to give 3 amounts. But if the AMH is more than 15, then in this case, I'm afraid that we have hyper response. So I'm going to cut down on the FSH, 2 ampoules only, not 3 ampoules, and also I'm going to use the antagonist protocol. If it's less than 5, then I'm expecting a poor response, so I'm going to use the antagonist protocol, but I'm going to increase the amount of FSH to 3 ampoules. And if it's less than 1, so it's a very poor response, so why spend the money? Let's go for natural cycles or modified natural cycle. This is what Nelson did. Yates did the same thing. Okay, he suggested this, but does it work? And he has another, this is on MH, and of course there is another one on AFC. This is Nelson again. But the question is, does it work? Before that, the other side of the coin is what Jovic from Perth in Australia did for hyper response. He did the same. So the question now, can we use these predictors to help us in stimulation protocol, in our protocols of stimulation? The short answer is no. And this is why. This is a study, a multi-center study, the so-called ESTER study. What they did, headed by Nivo Anderson, of course, with Bart Fauser here, Antonio Velasco here, and many people. What they did is that they said, okay, we are going to measure AMH. And according to the amount of AMH, the level of AMH, we are going to give our protocol. And this is the level of AMH, and this is the daily dose they started with. What did they find? They found that no change in ongoing pregnancy rate or in live birth rate, but what they could do is diminish ovarian hyperstimulation syndrome. Yes, you can diminish ovarian hyperstimulation syndrome, but you cannot increase your success rate. Another study is this study, the Optimus study by Theodora van Tilburg. And what they did something similar, but they used AFC to determine the amount of FSH they're going to use. And what they did, they found that the cumulative, if you're talking about all the patients they studied, the cumulative pregnancy rate was the same. While if you use AFC to help you, or if you don't use AFC, so it was the same. And if you divide them into poor responders, it's the same again, no change. It does not improve cumulative live birth rate. So in poor responders, it does not help you in cumulative birth rate. If you look at hyper responders, they did the same. It does not help you. It does not increase your success rate. It may diminish your ovarian stimulation syndrome. Yes, this is something you can do. So, to summarize, you cannot increase your success rate, but you can diminish your ovarian hyperstimulation syndrome. And this is what they found. The mild was diminished, the moderate was diminished, the ovarian hyperstimulation syndrome was diminished. So some people said, okay, let's combine the predictors. Instead of using one predictor, let's combine the predictors, like as we do in the nuclear translucency. If you use nuclear translucency alone, you have a certain predictor. If you add the hormones, you have the predictor. So you do the combined test, you have a better prediction. So they said maybe if you combine, we have a better prediction. And this is what Brower said. He said if we use age plus FSH, we will have a better predictor. Age plus AMH, age plus AFH, FC plus AMH plus FSH. ما حضرتك برضه لو تتفضل تتكلم بره القاعه يبقى كتر خيرك. معلش يعني كمل على مهلك بره يعني. So it's the same thing actually. If you want to predict ovarian reserve, so you have a beautiful curve, but if you are going to predict the clinical pregnancy, it is the same idea, because clinical pregnancy does not only depend on the response of the ovary. And this is what people did. Todorovic, she used many things. He used AFC plus ovarian volume plus power Doppler and so on, the constant and so on. Let's have a look. This is what Todorovic did. She used age, and she used interfollicle and ovarian and Doppler and age and so on. And she is the only person to say that this has improved her results. But it is a small study. It is the only study because people could not repeat this. Because when François Oliven tried to do the same thing using FSH, BMI, age, and AFC to determine the starting dose, his results were the same. No change in implantation rate, no change in clinical rate, and no change in live birth rate. And now we have the nomogram of Lamarca and Zunkara. What they said, okay, we have this nomogram. Give us the age, give us day 3 AMH, and give us the day 3 FSH, and we are going to tell you the starting dose. They have one of these nomograms for AMH. They have another one for AFC. They said, if you give us AFC, and you give us the age, and you give us day 3 FSH, we are going to tell you the starting dose of FSH. And does it work? Short answer, no. This is Allegra. He used the same, Lamarca and Zunkara nomogram, and with no change in fertilization, implantation, clinical pregnancy, and so on. It did not help them. And the same idea now of the Poseidon people. The Poseidon people said, we are going to combine the AFC, and I mean, you know, they have divided into young patients with good predictors, old patients with good predictors, young patients with poor predictors, and old patients with poor predictors, 4 groups, and they want to do this. We are waiting for the result. There is a study going on, and we are waiting for the results. But what the Cochrane tells us is that it doesn't help you. If you use these methods for prediction in all people, no change in live birth rate and ongoing pregnancy rate. If you do it for poor responders, no change in live birth or ongoing pregnancy rate. If you use it for hyper responders, no change in pregnancy rate or live birth rate. And this makes sense. Because what can you gain from flogging an already tired horse? The horse is already very tired. The ovary is already very tired. You're going to flog the ovary and go for the ovary. It's not going to produce more oocytes. But what you can do is to diminish the incidence of ovarian hyperstimulation. And this is where mild stimulation comes into play. So if you're going to spend all this money and at the end you're going to give the same response, maybe you should use mild stimulation protocol. But what is mild stimulation protocol? It is not natural cycle. It is not clomiphene citrate. It is not modified natural cycle. These are definition of the ISMAR group. It is using a small amount of FSH. You use a small amount of FSH with or without chlomine, but you use FSH. And does it work? Well, it is the same. Yani if you use, we did this meta-analysis and we published in the last SRM before the corona. It is the same. The clinical pregnancy rate is the same. If you use the conventional protocol and you spend a lot of money and down regulation, all these things, you end up with the same clinical pregnancy rate and the same ongoing pregnancy rate. And very quickly, Geet and Argon, the group of Clinical and and Stuart Campbell, they published this in RBM online in August 2020, and what they found, the same thing. If the live birth rate is the same, if you use the mild protocol or the conventional protocol in poor responders, mild stimulation also, the cycle cancellation rate was the same, even the embryo quality was the same. Now comes the Bologna criteria. In 2011, Bologna, the people, some group of very excellent doctors had a meeting in one of the very excellent results, and they came up with this definition. They said definition is 2 out of 3. Yani they are trying to imitate the PCOS definition. PCOS is an enigma. It is a syndrome. We don't know what it is. So we can have a consensus. But in poor responders, it is poor responder. It is not a consensus. It doesn't need a consensus. Anyway, they said 2 out of 3. Advanced maternal age, cutoff point 40. Who said cutoff point is 40? Al-Azami did receiver of predicate is found in 37. And the last study is 35, and that study 33. Cutoff point 3. Why 3? We found it 5. Other people found it 4. Other people found it. It is not evidence-based. They said, okay, and also ovarian reserve, AMH. Why is it 0.1 and 1.1? Dr. Iman موجودة معانا. She published a very beautiful study in fertility and sterility many years ago, and the cutoff point was not like this. But where did they get? يعني they got the numbers without evidence. So طبعا we criticized it. We wrote about it. لأنه كمان they said that it's the first time for somebody to define poor responders when we had published this in 2006. فيعني برضه افترى شوية. And other people criticize it also because it is not evidence-based. And there is more philosophical point. You can use predictors to predict, but you cannot use predictors to define. You are mixing the aim with the means. Yani predictors are predictors. You cannot use predictors to define. Okay. This is Bologna. This is Eschery. Who are we? اللي بيتكلموا فرنساوي عارفين بقى الفابل de la Fontaine. La raison du plus fort est toujours la meilleure. اللي هي معناها ايه؟ might is right. احنا مين؟ اشري قالت كده يبقى كل الناس تستعمل. يبقى ماشي ماشي. وبعدين بوسايدون نفس الحكايه. It's the same idea. They are mixing the aims with the means. We'll see what they are doing. Okay. But there is hope. The hope lies in genetics. Genetics بقى ايه؟ اللي هي اللي بنسميها SNPs. What is a SNP? Single nucleotide polymorphism. We know that this is the receptor of FSH. The FSH is a very big molecule, 22,400 Dalton, very big molecule, cannot go inside the cell. So it stops here, and this is the cell wall where it stops here, and this is the receptor. And in the receptor, if you look at the DNA of the receptor, sometimes there are mistakes. هنا بدل ما AT ادينين وثايمين، لا هنا في جوانين وسيتوزين، في غلطه صغيره، سنجل ميستيك سنيب. بس دي مهمه لان it changes the response. ففي سنيبس يعني اللي فيها جي جي الاف اس اس كونسنتري بتاعتها اقل من اللي فيها اي اي، واللي فيها اي سي اقل من الاي، واللي فيها جي جي زي اللي فيها اي سي. والستيميوليشن ديوريشن this one is shorter than this one, this one shorter than this one, and this one and this one are the same according to the work of Alvegi. So and this one also, the number of FSH received here is a high number if we use the same amount of FSH, وهنا high number وهنا is the same. It seems that the response will be with the genetics and epigenetics. So ladies and gentlemen, in conclusion, the true ovarian reserve is difficult to determine because it needs histology. Instead, we use the functional reserve to predict ovarian response. Many markers exist, but the two real ones are the AMH and the FC. Algorithms and nomograms have been devised to help the appropriate stimulation protocol and نختار protocol while starting those. But so far, randomized studies have shown that it does not work. You can diminish ovarian hyperstimulation syndrome, but you will never be able to increase your amount of follicles or oocytes. Sorry, more studies are needed to determine. Maybe we are using the wrong algorithm. Maybe this algorithm we don't know yet. Maybe they come up with another algorithm, or maybe the algorithm will not work, and the answer may lie with the steps. وطبعا when we say algorithm، ما اعرفش يمكن حضراتكم عارفين algorithm يعني الخوارزمي. الجوريزم كلمه الجوريزم يعني الخوارزمي اللي جاي من الخوارزم اللي هي النهارده اسمها كيفا في جمهوريه اوزبكستان جنب سمرقند وطشقند وبخارى.